Alrighty. Good evening, everyone. My name is Don Boudreau. I'm the manager of professional development here at the OPA. First, I'd like to thank everyone for taking time out of your schedule to join us this evening. I'd also like to acknowledge and thank Searchlight Pharma for supporting the development of this program through an educational grant. And I'd also like to very much thank our presenter, Victor, for preparing this presentation and sharing his expertise with us this evening.
Amazing. Thank you so much, Tom. It's such a pleasure to be here with everyone here today. So in terms of just a few housekeeping things as we begin, we wanted to start off with some disclosures. I currently have no past relationships, current or past relationships with any commercial entities. There is a speaker fee with the current program I received from the Ontario Pharmacists Association for this learning activity. In regards to commercial support, this program has received financial support from Searchlight Pharma in the form of an educational grant. Now, in regards to the learning objectives of today, by the end of the session, you should be able to explain the mechanisms of action of combined oral contraceptives that we'll refer to as COCs, including the distinct roles of estrogen and progestin. Compare and contrast different types of estrogens, progestins, and formulation used with COCs with respect to safety, efficacy, and side effect profiles. Assess and identify patient-specific factors, contraindications, and risks that guide the appropriate selection of COCs. Recognize common side effects and serious adverse events associated with COCs. And apply patient-centered decision-making techniques to recommend an appropriate COC based on formulation characteristics and patient preferences. Now, as Don mentioned, I wanted to keep this presentation very interactive. So what we'll do is we will start off with a question. So this is just general information if you know it. In what decade were COCs, so combined oral contraceptives, first approved for use in Canada? Is it A, 1950s, B, 1960s, C, 1970s, or D, 1980s? So we'll wait here for a few seconds as we wait for some answers. The 1950s, 1960s, 1970s, or 1980s? Okay, great. So it seems that most individuals voted for 1960s. And interestingly, that is absolutely correct. So interestingly, many people are surprised to learn that it wasn't until the late 1960s, at which time it was approved. So actually, in 1961, there was a product named Mestranol and also norethindrol. It was approved, but it's really only for menstrual disorders, not contraception. And it was only until 1969, after amendments to the criminal code, that COCs were approved for contraceptive use. By now, in the 21st century, COCs are really some of the most widely used contraceptives in Canada. So it's just to illustrate and fun fact to show that the pills journey in Canada is not just medical, it's also shaped by law, politics, and societal change. These days, COCs are the most frequently used hormonal contraceptives in Canada. It's used in about 44% of women, and it's only second to condoms at about 54% and the withdrawal method at about 12%. It is interesting to note the evolution of COCs, and the evolution is not all the same for all the products. Since it was inception, it's varied a lot in estrogen types. So whether it is ethinyl estradiol or versus estetrol, we'll talk about these differences later, and also differences in progestin type. These differences in components and formulations matter. They influence its efficacy, its side effects, and also safety risks such as thrombosis. COCs are extremely effective. With perfect use, they're extremely effective with a failure rate of only 0.3%. With typical use, though, its failure rate rises to about 9%, and this is mainly due to either missed pills, drug interactions, or oftentimes not restarting after the hormonal-free, pill-free interval. Adherence still remains a big challenge, as we all know as pharmacists. Around 60% of patients don't use COCs correctly, or they use it inconsistently, and this leads to a lot of issues. As well, the leading reason for discontinuation are side effects. And this is where we as pharmacists come in and why we're so critical. We're really important in terms of counseling as well as follow-up. And this is to ensure adherence, patient support, and also individualized selection. I also want to take a 10,000-foot view and take a look at the history of COCs in Canada. This is really out of interest. So you'll see that ethinyl estradiol that we're very familiar with, I'll call it EE because it's a mouthful. EE was actually first synthesized in 1938. Well, long before it was actually introduced. This EE became the foundation of most COCs that we know today. And again, as mentioned, it was until 1960s that the first generation of progestins, such as norethinostrol acetate and levonorgestrel, were first introduced. Interestingly, take a look at that red line. That's when the first case report of VTEs first happened. And this was related to the COC use. And since that time, this prompted a lot of reformulation aimed at improving safety of combined oral contraceptives. Since that time, doses of EE were lowered to reduce thrombotic events. New progestins were developed, and this helps to improve cycle control, tolerability, and also reduce androgenic side effects. And also, as we're all very familiar, regimens evolved. So now we, instead of just monophasic, we have also biphasic, triphasic, for instance. And you also notice in the purple, lots of different second and third generation different COCs, whether it's EE plus levonorgestrel or norethinostrol, strone, EE with desogestrel, gestodine, norgestimate. And these evolved over the time. And then as we eventually get into the 2000s, that's when recent developments such as drospirenone were introduced. Now, drospirenone, we'll talk about a little bit more. It's a spironolactone analog. And then by 2010, there was formulations of EE plus drospirenone. And then by 2020, most recently, there were newer formulations that finally changed the estrogen component. Instead of being EE, now it's estetrol, E4. Again, we'll talk about it more. E4 combined with drospirenone. And all of these different changes really reflect a balance between efficacy, safety, and also patient tolerability. So a quick crash course in terms of the history of combined oral contraceptives in Canada. Very interesting. So where do we come in? Where do pharmacists come in? And really, we're the key partner in terms of reproductive health across the continuum of care. We help to identify issues, guide prescribing decisions, tailor COC selection, help with education and counseling. And really, it's been shown that pharmacists have impacts in terms of increasing access, improving utilization, and improving adherence through the selection of estrogen types, progestins, dosing regimens, and assessment product selection, patient-centered counseling, and finally, monitoring and follow-up. And you'll notice here on the fifth point, in many provinces, other than Ontario, pharmacists can also prescribe for combined oral contraceptives. So maybe that will be potentially one day in our future as well. Potentially, we'll see. Okay, great. So all throughout this presentation, we're going to have a practical scenario to help apply our knowledge throughout this presentation. So meet Olivia. Olivia is a 22-year-old, a healthy woman who comes to your pharmacy asking about starting COCs, combined oral contraceptives. Her main priority is contraceptive effectiveness, safety, and this is specifically around the risk of blood clots, because she's heard from others that combined oral contraceptives carry a small risk of blood clots. So the question for us to think about as we walk through this presentation is, what information, first of all, do we need to gather to decide if COCs are safe and appropriate for Olivia? Okay, so let's start with talking about assessing the patient. So the first step in assessing COC suitability is through a thorough patient history. So what does this include? This includes age, weight, height, medical conditions, comorbidities such as hypertension, cardiovascular disease, cancer, current medications, menstrual and contraceptive history, and social factors, especially smoking. I want everyone to remember this, smoking. We'll talk about this in the next slide. And also, of course, rule out any pregnancy. Now you'll note I mentioned weight in that very first line and obesity in the second one. I want to note that obesity is not a contraindication. It does increase the risk of venous thromboembolisms, but it is not a contraindication. It is important for us as pharmacists to weigh the risks versus benefits. Other information that we'll need to gather are drug interactions, potential drug interactions. So any CYP 450 inducers, such as anticonvulsants, rifampin, St. John's worts. These can help. This can potentially reduce the efficacy of COCs. And the reason is because the traditional estrogen, ethinyl estradiol, and also the progestins, they're metabolized through CYP3A4 and CYP1A2. And of course, contraindications I'll talk about next. But other than medical safety, it is really important for us to consider patient preferences. So consider what patients value most in terms of cycle control, side effect profile, non-contraceptive benefits. And also, important to discuss other alternatives such as long-acting reversible contraceptives or even progestin-only pills. So really, the thing I want to take away for everyone is that assessment isn't just looking at risks. It's also about combining clinical screening with patient priorities to really select the safest, most suitable option. Now, in regards to the absolute contraindications, I'm just going to quickly read through all of these because these are very key. These are very key red flags to know when either selecting COCs or even in the future, perhaps potentially prescribing for COCs. So these include contraindications that can increase the risk of serious or life-threatening complications, such as cancer or cardiovascular disease, such as breast or other hormone-dependent cancers, history of stroke or cerebral vascular accidents, complications of valvular heart disease, current or past VTE or pulmonary embolisms, or any thrombogenic mutations, history of myocardial infarctions or ischemic heart disease, and diabetes with microvascular complications. Also consider systemic risks such as uncontrolled hypertension and also severe liver disease such as cirrhosis or hepatic tumors. And of course, pregnancy and postpartum. COCs, understandably, are contraindicated in current pregnancy. But this is interesting. Keep in mind, it's also contraindicated if the woman is less than 6 weeks postpartum if breastfeeding. Yeah. Also, flag for neurologic red flags such as migraine with aura, and this at any age, and this is an absolute contraindication, and smoking, going back to smoking, particularly in women over the age of 35 years old who smoke equal or more than 15 cigarettes per day, because this combination substantially increases the risk of a myocardial infarction or stroke or clots. So the key is, of course, that these are the red flags. If they are prescribed, COCs should not be prescribed, and as such, a pharmacist can guide patients towards either progestin-only pills or either some non-hormonal alternatives. So with that, let's quickly pause here and check our understanding. So, pop quiz. A 38-year-old woman presents to your pharmacy. She asks about COCs. Her medical history are as follows. She has a history of benign ovarian cysts that was surgically removed at 30. She previously had an ischemic stroke at age 36 and has ongoing treatment of seizures. She smokes about 20 cigarettes per day, and she also takes carbamazepine for seizure control. So what best describes her suitability for COC use? Is it A, the first one, she can use COCs because her ovarian cyst was benign and was surgically removed? Is it B, she should just avoid all COCs, or COCs in general, due to her history of ischemic stroke, her age, and her current smoking status? Is it C, she can use COCs, but warn her that carbamazepine will reduce their efficacy, COC's efficacy, through CYP 450 induction? Or D, she can use COCs, but just have to monitor closely for any clotting risk? We'll pause here for a few seconds just to see what everybody thinks. Okay, great, amazing. So looks like almost everyone answered the correct answer, which is B. So she should avoid COCs due to her history of ischemic stroke, age, current smoking status, and of course, carbamazepine as well. Okay, wonderful. So back to our case study. Okay, Olivia, the patient that was at your pharmacy, she now raises a very common concern. She asks you, is one birth control pill safer or more effective than another? What's the differences? She's especially worried about blood clots, as I mentioned before. And this is a very good opportunity for us now to describe, as pharmacists, the different types of estrogen and the different types of progestin so that we can properly communicate this to the patient and also help her select the most appropriate formulation for her. So let's first start off with the mechanism of action of COCs. COCs are very effective. They are designed to optimize ovulation suppression, and this is done while balancing the estrogen effects and also the progestin effects. So let's start with the progestin effects on the left-hand side. Progestin's role is that it provides the main contraceptive effect of COCs. They do this by exerting negative feedback on the hypothalamus and pituitary glands, and this decreases the gonadotropin-releasing hormone, the luteinizing hormone, and the follicular-stimulating hormone that blocks the mid-cycle luteinizing hormone surge, ultimately preventing ovulation. Moreover, on top of that, it also thickens the cervical mucus, and this makes it really hard for the sperm to enter the uterus. And in addition, it also causes endometrial thinning and atrophy, and this makes implantation even less likely. So it's a multitude of different things. As well, it also reduces the risk of endometrial hyperplasia for patients who are taking estrogen. So a variety of different things that progestin is doing. On the flip side, estrogen. Estrogen really provides the main role in terms of endometrial stability, and this is with the aim of consistent cycle control. It does also have a minor role in terms of inhibiting follicular development by exerting a negative feedback on the pituitary gland, and this decreases follicular stimulating hormone. So it does have a minor contraceptive effect as well, but mainly it's really for cycle control and bleeding pattern. It also prevents estrogen deficiency symptoms. This includes things like hot flashes, bone effects, and also balances the progestin's endometrial effects to reduce breakthrough bleeding. So really, the takeaway that I want for everyone to have from this slide is that really it's together, progestin, estrogen, together, they act synergistically with progestin stopping ovulation and sperm entry, and estrogen really stabilizing the endometrium and making sure that the cycles are predictable. And really together, this is what makes COCs highly effective and really generally well tolerated since its inception by patients. So that was a mouthful. One more quick poll, just to see if how many people caught on to that. So imagine, hypothetical case, patient asks, I know COCs stop ovulation, but what exactly do these two hormones do? What does estrogen and progestin actually do? What's the best explanation, or what's the most accurate explanation? Is it A, estrogen makes the cervical mucus thick while progestin keeps the uterus lining steady? B, estrogen mainly keeps the uterus lining stable while progestin stops sperm and ovulation? Is it C, estrogen prevents a fertilized egg from attaching while progestin stops eggs from growing? Or is it D, estrogen's main role is to maintain cycle control and bleeding pattern and prevent side effects from low estrogen, while progestin provides the main contraceptive effect by suppressing ovulation, thickening cervical mucus, and thinning the uterine lining? So I'll give a few seconds just to see what individuals choose for this quick check your understanding poll. Amazing, great job, everyone. Vast majority chose D. Estrogen's main role really is to help stabilize the endometrium, helping with cycle control, suppressing ovulation as a minor effect. Really, progestin is the primary hormone responsible for preventing pregnancy, blocking sperm entry, reducing chance of implantation, stopping egg release. Amazing, 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 amazing job. Wonderful. Okay, let's jump into estrogens first, then jump into progestins. Let's get really deep and dirty in terms of the science. Okay. As we saw, the backbone of estrogen and COCs has traditionally been ethinyl estradiol, right? EE. EE is and has been revolutionary due to its chemical modification. You'll notice that there is an ethinyl group at the 17th position, and this gave EE a much longer half-life and higher potency than E2, the estradiol. Really, this formulation was revolutionary because it allowed for once daily dosing and also allowed for reliable contraceptive efficacy. And this is the reason why it has been the standard worldwide for decades, since the 1960s. It's well studied, there's decades of clinical experience, and there's a large body of safety and efficacy data. This also been consistently effective, even down to lower doses, so down to 20 micrograms or lower, and it also has a lot of dosing flexibility that's allowed tailoring to minimize the side effects and bleeding concerns that we'll touch on. Despite the strengths, there are limitations too. EE is metabolized by CYP450 enzymes. So this, of course, as we talked about in terms of drug-drug interactions, this increases the risk of drug-drug interactions. And also, it does have hepatic effects, so effects on the liver. And this contributes to increased protein synthesis, such as clotting factors. And this is linked to higher risks of VTE, particularly at higher dose. And that's why these risks are linked, right? VTE linked with birth control pills. Okay, that's the left-hand side. Let's take a look at the right-hand side. Taking a look at estetrol. Again, this has just recently come up in the past few years. We'll call it E4. So E4, unlike EE, it's a naturally occurring estrogen, and it's typically produced in the fetal liver during pregnancy. However, within the COC formulation, it's synthesized from plant sources, but it's a natural formulation. Unlike EE, it is structurally distinct. You'll notice that it has 4 hydroxyl groups, and this is what gives it its unique metabolic profile. E4 is rapidly absorbed and has 70% bioavailability, and similarly, it has a very long half-life of over 24 hours. We'll touch on this later, but it's primarily metabolized not by CYP450 enzymes. It's metabolized through glucuronidation and sulfation. And this means that there's fewer drug-drug interactions. It's not through P450. So takeaway is that our formulations in COCs still really have 2 estrogen forms. EE, again, a trusted, effective option, has been used long-term in terms of a history. E4, a new estrogen, new in terms of its use in COCs, with a lot of new pharmacologic advantages, a new natural estrogen, advantages specifically around metabolism and potential safety, and its clinical adoption is extremely new and it's currently evolving. Okay, let's talk about estrogen safety and efficacy. In regards to efficacy, contraceptive efficacy, Across doses, so ranges 20 micrograms higher, contraceptive efficacy has been shown to be similar. And this is really through the combined effect of the estrogen and the progestin. So for instance, there was a meta-analysis of 13 trials that showed that 20 micrograms of EE works just as well as higher dosed formulations. Similarly, E4, estetrol, the new estrogen, is also shown in studies to have comparable efficacy, so comparable efficacy to EE in the clinical studies. That's contraceptive efficacy. In regards to safety concerns, with EE, there is concern about a dose-related risk with venous thromboembolisms. Yeah, and also cardiovascular events. And the reason is because EE induces hepatic enzymes, as I mentioned in the previous slide. This increases protein liver protein synthesis and alters coagulation and alters fibrinolysis, which can increase clot risk. This is an interesting fact, and I want everyone to remember this as pharmacists, as we counsel patients and monitor our patients. The risk of blood clots is highest within the first year of use, as well as higher with higher EE doses. Yeah, right. I do want to take a breath here and put the risk of VTE in perspective. The absolute incidence of VTE still is low. It's about 5 to 12 cases, depending upon the study you look at, per 10,000 woman years, depending upon the formulation. But why is this still significant? Well, the reason is because so many women take COCs that at a population level, the impact is significant from a public health standpoint. Okay, great. So really the key message is that both EE and E4 are equally efficacious in terms of its contraceptive efficacy. And really the choice of estrogen, really as clinicians, we really need to weigh the individual patient risk factors, such as VTE risk, cardiovascular health, alongside patient values, their preferences, and their tolerability. So let's take a little deeper dive, first into EE, dose and safety, and then into E4, dose and safety. So let's touch on EE, the traditional ethinyl estradiol first. This is the most common estrogen. Okay. So you'll notice on the market, there's a lot of different formulations, a lot of different doses of EE. I'm going to have a chart later that you're going to see all of the different multitude of formulations. So how come there's so many different doses? How come the doses have changed? And the reason is because they've been trying to mitigate VTE and cardiovascular risk. And that's why through time, EE doses and COCs have been reduced to mitigate these risks. The problem is that EE dosing is really a balancing act. Higher doses provide good cycle control, but there is a cost, and the cost is side effects and potentially increased risk of VTE. On the flip side, lower doses reduce risk, but then tolerability becomes a challenge. So what do I mean by that? Very quickly, higher doses are, for instance, 30 micrograms. Predictable bleeding, over 90% of cycles have scheduled bleeding. It's a great regularity for the 7-day hormone-free interval, but increased risk of side effects such as headache, nausea, breast tenderness, and premenstrual tension. Okay. Then, flip side, lower EE doses. So we're talking about 20 micrograms or less. So the main goal is really to reduce VTE risk, but the trade-off then is more unscheduled bleeding, which is, as mentioned very early on, a common cause of discontinuation. Interestingly, there are studies, current evidence, that show, or rather disprove, that 20 micrograms may not necessarily be any safer than 30 to 35 micrograms. So maybe it's not even sometimes a better choice. The studies will be in the references. Then we have ultra low EE doses, which is 10 micrograms. And this is unfortunately associated with very irregular bleeding patterns. So for instance, scheduled bleeding drops significantly from about 43% in the first cycle to, by the time the patient takes a 12th cycle, drops to about 23%. 23%. And unfortunately, this unpredictability often impacts satisfaction and negatively impacts adherence as well. Not on the slide, but I feel it's my duty to mention it. When advising patients about starting these doses, you'll see lots of different microgram doses of EE. The general recommendation is to start at a lower EE dose, so around 20 micrograms. Start them around 20 micrograms, and then monitor and adjust if bleeding persists. Again, it's a trade-off. However, I want to note one thing. If the individual is an adolescent, SOGC recommends that doses of 30 micrograms or more is recommended to prevent bone mineralization concerns. So again, takeaway from this slide is that really EE dosing, when we come to dose EE, whether advising or one-day prescribing, it really is a balancing act. The higher the EE, that we're going to have better cycle control. Lower EE, better tolerability. The choice really should be guided by patient priorities, and then monitor and have the flexibility to adjust if bleeding or side effects are problematic. Okay, so that's EE. Quick shift now to E4, the other estrogen that's just a few years on the market. So EE does have a unique profile that's distinct. E4 does have a unique profile from EE. So E4 is very unique from EE in that E4, so estetrol, has tissue selective activity. It acts both as an agonist or an antagonist depending on the site with which it's acting. And this makes it very different from traditional estrogens and really can help explain some of its safety profiles. So in terms of its agonist activity, so that's on the left-hand side of this slide. It acts as an agonist on the vagina, uterus, endometrium, bone, and brain. So these agonist activities can help support contraceptive efficacy, cycle control, bone health, and potentially mood stabilization. As an antagonist, this is where it also offers potential safety advantages. So it's an antagonist in breast tissue, for instance, and this can potentially reduce stimulation of breast cells compared to EE. And also it can theoretically lower the risk of estrogen-related breast effects. It's also an antagonist for the liver. So unlike EE, which induces hepatic proteins, E4 has minimal effects on liver metabolism. Not only in terms of drug interactions, it also means that there's less impact on lipid metabolism, coagulation factors, and biomarkers for thrombotic risk, such as normalized activator protein C sensitivity ratios. So really kind of to summarize it, this agonist, antagonist type of selective action really help to explain why E4 containing COCs really help to offer that predictable bleeding pattern, but more importantly, also potentially lower the cardiovascular and thrombotic risks as well. Diving a little bit into its metabolism, E4 has a long half-life of about 24 to 32 hours, excreted mainly through urine, there's no active and no carcinogenic metabolites. It is metabolized through glucuronidation and sulfation. And once eliminated, E4 doesn't have any residual estrogenic effects on the environment. Again, as I mentioned, it's not metabolized by P450, so E4 will not have the same drug interactions as EE, but this is very key. I want to note that the contraindications of E4 products still remain the same as the EE containing contraceptives. And this is very, very important, specifically in regards to the inclusion of drospirenone. So while E4 itself can avoid any CYP450 interactions, the drospirenone component in these products still is metabolized by CYP3A4. Again, any CYP3A4 inducers should be avoided. And if taken together, patients should use backup non-hormonal contraceptive methods during treatment and for about 28 days after stopping the inducer. Okay, great. So, quick question. This is something that we haven't covered yet. Just thought it'd be fun to ask. Progestins in COCs are often classified into generations: first generation, second generation, third generations. Does anyone know why they are classified this way? Is it A, because of the chemical structure of the progestin? Is it B, the order in which the progestins were developed and introduced to the market? C, their relative androgenic activity? Or D, their effectiveness in preventing pregnancy? Interesting. So give a few seconds to see what people think. This is a fun one. This is a good cocktail party question that you can ask your other pharmacy friends on the chat about. Great, so let's see what people say. Okay, it's a mix of B and C. Most people saying B, and that is absolutely correct. That is the correct answer. So progestins are often denominated as first, second, or third generation. And there's also the drospirenone as well. It doesn't fall into first, second, or third. It's really based on when they came to market, not the structural or physiological differences. Also really wanted to note, generation does not reflect superiority. Because it's a higher generation does not mean that it's necessarily a better product. Let's say it's really patient preference and tailored to the patient. So high levels, structurally, most progestins are derived from testosterone, and they really fall into two groups. There's estranes, such as norethindrone, and also gonanes, such as levonorgestrel, norgestimate, desogestrel. And their effects really change depending upon what influences their progestin potency, their androgenicity, their side effect profile. Uniquely, there is a other class, which is drospirenone. Now, drospirenone is structurally distinct. It's derived from spironolactone instead of testosterone. And because of this, it has anti-androgenic effects and anti-mineralocorticoid properties. That means it can help with symptoms such as bloating, water retention, and it can also counteract a lot of estrogen-related fluid retention. Despite the anti-androgenic side effects, I want to note, it's a fun fact, that studies actually show that there's no consistent advantage over other COCs for acne or hirsutism treatment, interestingly. And in regards, because it is derived from spironolactone, drospirenone does have a potassium-sparing effect. But of note, so as pharmacists, I want to note this. In healthy patients, the risk of hyperkalemia is not increased. Hyperkalemia is not increased. Monitoring, though, is needed under special circumstances. So if the patient is on any potassium sparing or potassium increasing drugs, or if they have renal disease or adrenal sufficiency, they should be monitored for potassium. So the key takeaway of this is that lots of different potassiums, really the choice is based on individual tolerability and side effect profile. Overall, though, efficacy, contraceptive efficacy, is similar across progestins. The clinical decisions should be based on patient need, comorbidities, and preferences. A little bit more now, actually, on this slide here. Again, efficacy is similar across all progestin types. Even though direct comparative trial data is limited, what is available shows that there's no meaningful differences in terms of preventing pregnancy. The side effect profile, here's where it kind of is interesting. Third generation progestins and also drospirenone generally are less androgenic or anti-androgenic. So there's fewer androgen-related side effects, such as skin effects, hair effects, acne, hirsutism, And this can improve tolerability for some women. We're all wondering about VTE risk. How does VTE risk compare for progestins? This area has a lot of debate, Some of the older case-controlled and retrospective cohort studies showed that there was a higher risk of VTE in third-generation progestins and drospirenone compared to earlier generations. But then, later on, prospective cohort studies did not confirm an increased risk. So now, evidence is very mixed. And so that's why the guidelines are very cautious. So SOGC, so Society of Obstetricians and Gynecologists in Canada, their recommendations in terms of their most recent guidelines is that differences in progestin type are not strong enough to justify preferential prescribing purely based on VTE risk. And so I'm just quoting them. It does not strong enough to justify preferential prescribing based on VTE risk. So instead, what does that mean for us? Really, progestin selection really should focus more on side effect profile and patient preferences instead of VTE differences. And all, again, progestins are equally effective in terms of contraception. So this is the fun table. Lots of product. I'm not going to go through all the different products, but just want to show in terms of EE-containing COCs, really they differ, again, of course, in terms of different strengths of EE, but also in terms of the generations of progestin. And you'll notice as you take a look into the right-hand side, that's really where it affects the androgenic activities as well. So really kind of the key point of this is that contraceptive efficacy, again, is similar across all these options. What really differs is tolerability and side effect profile. So when you have time to really kind of take a look more closely at the chart, but really it is the different generations and progestins will affect the androgenic activity, which affects side effects. Okay, now back to our case study. So Olivia is back, and now she's wondering, okay, so I've heard that there's different schedules and regimens. Are some easier to manage or are some more effective? This is actually a really common patient questions because there's so many different dosing regimens that determine convenience, adherence, and patient satisfactions. So let's talk about some of the options, evidence, the trade-offs now in the next slide. Again, this could be a lot of recap for those of us, but there might be some interesting tidbits in this. Okay. So as we're aware, COCs come in different regimens. There's cyclic forms, shortened hormone-free forms, there's extended forms. The traditional one that we've always seen is the 21-7 regimen, which is 21 active pills and 7 sugar pills, so the hormone-free days. And this has been used for decades and really provides generally very predictable cycles in general. Some of the newer formulations now, you'll notice, have 24-4 regimens. So that's 24 active pills and 4 non-active pills. Why? Why have they started coming up with this formulation? And the reason is why is because it reduces the chance of escape ovulation. So in the trials, they found that with this type of 24-4 regimen, fewer women ovulated on this regimen versus the 21-7, even when pills were missed. Also, this regimen reduces hormone fluctuation, side effects including nausea, headache, and mood changes. Lastly, there's also extended regimens such as 84-7, for instance, so 84 active pills, and then after that, there's 7-day hormone-free pills. So this allows for bleeding once every 3 months, and these formulations are preferable for patients who want less frequent periods. Some individuals experience very, very problematic periods, or just in terms of convenience, they want less frequent periods. The key point to note is that all of these regimens are generally equally efficacious in terms of preventing pregnancy with similar failure rates if taken perfectly And really the choice comes down to patient preference and tolerability. So, for instance, in Olivia's case, options include a lower EE product or even some of the more modern E4 drospirenone formulations that are now 24/4 that has a better escape ovulation and potentially decreased side effects. That's what the studies show. That helped improve tolerability. So back to Olivia. In her case, she's feeling nervous about the pill. She's heard now, we're now into side effects. She's heard from stories from friends. The pills cause things like nausea, mood swings, spotting, weight gain. She asks you, what should I expect? What should I do if I have side effects? So how should we respond? And with that, we jump to one of our last questions for this evening, which is, we'll cover this later, but which of the following is a common but usually self-limiting side effect experienced by women? Oh, actually, the answer is B. Not weight gain. Weight gain is actually a myth. Weight gain generally is not associated with combined oral contraceptives. It is B, nausea and breast tenderness. Nausea and breast tenderness is usually a common but self-limiting side effect in terms of the side effects usually resolve in about 3 to 6 months. 3 to 6 months. Yeah. The reason why hypertension and deep vein thrombosis are not the answer is that they're not common. They are considered rare but very serious adverse events rather than common adverse drug reactions. Okay, so more thoroughly, let's talk about the common adverse drug reactions. So in terms of the early side effects, these are usually quite mild. These include nausea, breast tenderness, abdominal cramps, headaches, sometimes a decrease in libido. And in terms of frequency, it usually occurs in fewer than 10% of users and usually resolve within the first 3 to 6 months. I know I mentioned this before, but I wanted to double down on this. Studies show that there's no strong evidence linking COCs to weight gain, but it is something that patients worry about very frequently. So this is the reason why reassurance and good counseling for us as pharmacists really matter, because these conversations can help prevent unnecessary discontinuation. Breakthrough bleeding is also one of the most frequent reasons that patients stop taking the pill. Again, it's more frequent and more common with ultra-low dose estrogen formulations, so that's less than 20 micrograms of EE or continuous regimens. Sometimes it does improve with time, but if it does persist, we should take a stepwise approach to make sure and rule out any other causes, such as missed pills, underlying conditions, and then consider adjusting the dose, sometimes moving even up to 30 to 35 micrograms of EE, which can help improve stability, or switching to E4, estetrol, or a different progestin may help. For patients who are taking a continuous regimen, a short 3 to 4 day break can also help to reset the cycle and resolve any bleeding. So the key point I want to leave with you is that these side effects are manageable and temporary, and the pharmacist, us, play a key role in guiding patients through this early adjustment period. In regards to VTE risk, because this is a big concern that a lot of patients have, it's important to note that it is rare, but it is serious, specifically with the VTE. The reason why is because estrogens and COCs, traditional estrogens, can shift the balance in the coagulation system and increase clotting factors, and also reduce any anticoagulant activities. And this really creates a state of hypercoagulability. Progestins themselves are not strongly thrombotic, but they do modulate and influence overall risk when combined with the estrogen. So you'll see here on this scale, this kind of diagram, showing that on the left side, there are the prothrombotic effects, such as increased activated protein C resistance. And on the right-hand side, there's going to be antithrombotic factors such as protein C and plasminogen, which can be outweighed by the prothrombotic changes. So really wanted to, I know we touched on this, is that absolute risk of VTE is generally low. Absolute risk is low. But because so many people take it, it is a serious public health consideration. So patient counseling and decision-making is very important. And that's why it is very important to weigh the benefits and differences between EE and E4 and its impact on the homeostatic parameters. In terms of patient counseling, the good mnemonic to remember for counseling patients is the ACHES warning sign. So that's ACHES. To counsel patients to monitor for these few things: abdominal pain, chest pain, sudden headache, so sudden and severe, could indicate, for instance, a stroke, eye problems such as vision loss, blurred vision, and also severe leg pain, could be possible DVT. So patients should be taught to monitor for these items, and also monitoring for blood pressure is also essential since hypertension can increase cardiovascular risk when combined with estrogen-containing COCs. And then the last piece is in terms of the differences between the estrogens. This is a study that was out in 2020, numerous studies as recent as 2020. And this showed that traditional EE containing products do significantly increase activated protein C resistance, whereas E4 combined with drospirenone shows a much smaller impact, so it suggests a more favorable profile on clotting risk. So the takeaway is ACHES. Remember the ACHES in terms of counseling patients, and also choice of estrogen matters. The differences will impact clotting risk and thrombotic parameters. Okay. And very quickly, just to wrap up just a few more slides. In 2024, there was a study that analyzed over 78,000 contraceptive-related events in Europe. This was through Vigilance. And they actually found a very interesting thing. They looked at the risk of VTEs in terms of COCs. So they looked at something called proportional reporting ratios, PRR, which is really how often VTE events are reported for any specific oral contraceptive product. What they found is that similar to the last slide, to support it, drospirenone stood out with the highest proportional reporting ratio of VTEs at 2.66. And in contrast, the E4, the neuroestrogen, estetrol, with drospirenone, showed actually the lowest proportional reporting ratio. So it had a 0.24, which showed that it was really equal to just progestin-only formulations. So suggesting that E4 formulations really, at least based on the findings in the study, show a much lower, really low thrombotic risk compared to E4. So something to keep in mind in terms of when we think about personalizing estrogens for a more safer contraceptive option. And lastly, before we go to monitoring follow-up, just want to also mention that COCs also play more of a role than just contraception. They also play a role in terms of improving quality of life, in terms of menstrual-related symptoms. Up to 80% of reproductive age women have physical changes, as many as half experience menstrual pain. And that's a lot of reasons why a lot of women avoid or discontinuing CCs. A lot of the newer formulations, such as E4 in the studies, have shown significant improvements in menstrual-related symptoms such as pain, water retention, and mood. So a lot of improvements there that really supports quality of life and overall health and lifestyle improvements. So just to wrap up the presentation, I know we're getting close to time, wanted to just now talk about monitoring follow-up. In terms of monitoring follow-up, the best practice is to monitor within 1 to 3 months, ideally within the patient's next refill. We should, as pharmacists, assess adherence, any health changes, review any side effects, monitor any blood pressure readings, particularly if they're over 140/90, then they definitely warrant follow-up and referral to a prescriber. And really to reinforce any key counseling points and to address any concerns early. So back to Olivia. Really wrapping it all up, how do we apply a patient-centered approach to COC selection? So what does the guidance say? In general, patient-centered decision-making should be as follows. This is the heart, really, of our clinical expertise and professionalism. Really, it should be aligned with patients' goals, preferences, and lived experience. So again, as we start off this presentation, it should involve individualized clinical assessment, looking at the medical history, contraindications, current medications, lifestyle, social circumstances, values. Then we should engage the patients. Beyond just a checklist, we need to ask and understand what matters most to the patient. Talk about and ask them about their past experience with contraceptions, their dosing preferences, their side effect tolerance, and the benefits that they're hoping for. And then have a shared decision-making, making sure that the patient is an active participant in choosing the method, choosing the formulation, and together coming up with the final choice. Lastly, ongoing communication and follow-up. Care doesn't end at dispensing or prescribing. Follow up within the 1 to 3 months, monitor adherence, side effects, satisfaction, and then adapt and evolve based on how the patient finds it. I do want to highlight one tool, if you're by the computer, just to type that in. This is the Combined Hormonal Contraceptive Practice Tool. It was designed as a Canadian tool, designed to help pharmacists help with COC selection and prescribing. I know we can't prescribe yet in Ontario, but still, it is very useful for us as a tool, evidence-based tool to help us with COC selection. And if and when the time comes for prescribing, it will definitely be of value. So just wrapping it up, in terms of the key points of the presentation, COCs are highly effective, but adherence and side effects remain key challenges. Estrogen choice matters. EE is long-term established in terms of its effectiveness and tolerability. E4, however, now offers a newer option with distinct safety in bleeding and tolerability profiles. Progestin differs in side effects and tolerability, although all are equally effective for contraception. Consider the regimen flexibility 21/7, the newer 24/4, and also extended or continuous formulation to tailor to their lifestyle and preferences. And monitor side effects. Most are mild and temporary. Counseling helps to reduce discontinuation and improve adherence. And side effects risks are rare, but us as pharmacists, we play an active role, a critical role in monitoring and counseling on red flags. But most of all, it really should be about patient-centered care and follow-up, really to drive home safety, satisfaction, and adherence. And that wraps up the presentation. Thank you so much, everyone. I'll pass it back to Dom.
Excellent. Thank you, Victor. I'd just like to quickly call out, I put the link that you had shared there in the chat to everyone, so you should be able to find that in the chat box. I'd also like to let everyone know if they have any questions at all for Victor, now would be the time to please type them into the chat. We do actually have one question from RL. The question is, I noticed that PE was not mentioned. Is there no increased risk of PE?
Oh, yes. So in regards to the PE, so it's pulmonary embolisms. In regards to the formulations, um, the risk of the PEs is measured as well. In terms of the specific data of the PEs, I'd have to kind of get back to you in terms of the specific numbers. But certain progestins have been linked to higher rates of pulmonary embolisms, but oftentimes it is grouped into venous thromboembolisms as well. But in terms of the specific numbers, I'll have to get that back to
Sure,
you.
no problem. Yeah, if the audience guest would like to send an email to education@opatoday.com, we can make sure that you get that information. I'll make one last call for any questions. We do not have any other questions beyond that, so I will sign off shortly. We'll just give everyone about 10 seconds to type in your questions. In the meantime, if there's no questions, I would like to thank everyone for joining us this evening. I'd also like to thank Searchlight Pharma for supporting the development of this program with an educational grant. And I'd like to very, very much thank our presenter, Victor, for coming by and sharing your vast expertise with us this evening. A great presentation. I certainly hope it's increased the confidence of everybody in the topic. Oh, we have a follow-up from RL, says, I usually counsel on headache, trouble breathing, or leg pain in case a blood clot goes to either of those places. Thank you for your time. So just a comment, and we'll sign off there. Thanks, everybody. Have a great evening. Bye-bye.
Well, bye.